Thank you very much and for the invitation and welcome to the Oncolor Colloquium on Radiation Therapy Breast Cancer 2025. This is my conflict of interest statements. I'm Icro Meattini, Associate Professor of Clinical Oncology at the University of Florence, Florence, Italy. So let's start from the end of 2024 and beginning of 2025. We presented in San Antonio the interim analysis of the EUROPA trial, phase 3 trial comparing radiotherapy only single modality option as compared to endocrine therapy single modality option for patients that receive breast-conserving surgery aged more than 70 years old affected by luminal A-like breast cancer. This is the design, the eligibility key criteria, and the primary endpoints of the study, ipsilateral breast tumor recurrence at 5 years, and health-related quality of life based on global health status and ERTC questionnaires at 2 years. These are the main results in terms of health-related quality of life, the baseline and the 24-month adjusted based on age and G8. In the radiotherapy arm, there's a differences at 24 months, so 3 points as compared to the almost 10 points in the endocrine therapy arms. The adjusted mean difference is around 7 points at the interim analysis favoring the radiotherapy only arm. Concerning the safety and treatment-related, treatment-emergent adverse events, we recorded 67% of any treatment-related adverse events in the radiotherapy arm as compared to 85% in the endocrine therapy arm, thus confirming the significant impact on health-related quality of life. So these are the main conclusions and current interpretation of data that at 24 months in terms of quality of life, endocrine therapy is related to an increased deterioration in terms of global health status as compared to radiation therapy. Concerning the early safety profile, fewer treatment-related adverse events were observed in the radiotherapy only arm. So this is an interim analysis, so it's not practice changing yet, but supports in principle radiotherapy only a single modality option in selected older low-risk luminal A-like patients, while of course awaiting for ipsilateral breast tumor recurrence and longer follow-up. The trial met the target around 1,000 patients, closed in March 2025. The NCCN guidelines version 1 2026 already consider partial breast, oval breast for selected patients at low risk, consider omission of radiation therapy, but based on this data, also the chance to omit endocrine therapy based on, of course, discussion with the patients. But 2025 was a very important year in terms of radiation therapy. These are the results of the import law, MRT partial breast reduced dose as compared to whole breast 10-year results for patients with low risk randomized to receive whole breast or partial breast irradiation using an MRT technique. This is the 10 years results. No differences in terms of ipsilateral breast tumor recurrence, very few events, 2.8% cumulative incidence for the whole breast, below 2% in the reduced dose arm, 3% recurrence in the partial breast arm, with an estimate absolute differences as compared to whole breast of around 1% in the reduced dose arm and 0 in the partial breast arm. Adverse events, similar or low levels of moderate marked effect across groups that favor overall the partial breast. So this long-term follow-up reinforces that partial breast MRT It's a safe option, very effective as compared to whole breast irradiation, and is considered a standard care for this population with a 10 years IPSI database tumor recurrence risk of 3%. The regimen was a 15 fractions, so this is relevant when discussed de-escalation strategies, including moderate and ultra hypofractionation. This is also the year of the SUPREMO trial, post-mastectomy chest wall irradiation in intermediate risk early breast cancer. The controversy here is the benefit of chest wall irradiation after mastectomy in intermediate risk disease, PN1 as defined 1 to 3 nodes, or selected non-negative with high risk features. This phase 3 trial compared chest wall irradiation as compared to no chest wall irradiation with a primary endpoint of overall survival at 10 years. And these are the eligibility criteria. Results, the intent to treat analysis show very few events. The efficacy at 10 years, overall survival 81% chest wall irradiation as compared to 81% in no chest wall irradiation with no specific differences. In terms of chest wall recurrences, patients receiving radiotherapy experienced less chest wall recurrence, no impact in terms of disease-free survival, and distant metastasis-free survival. So this is very important results. No overall survival benefit from routine chest wall irradiation in this intermediate risk population treated with contemporary systemic therapy, so supports de-escalation. But there are some key limitations yet. The long accrual with evolving systemic therapy, imaging, pathology, and radiotherapy techniques, of course, affect the results. The auxiliary management, these patients were treated in a period where more extensive auxiliary surgery were performed, higher nodal burden, frequent axillary lymph node dissection, basically not reflecting overall the current de-escalated practice in terms of axillary surgery. There's some population heterogeneity, and of course, low event rates with lower than expected local regional relapse rates that, of course, reduce the statistical power of the trial. So, of course, these are very important results, but do not close the post-mastectomy radiotherapy question in this era of auxiliary de-escalation and biology-driven selection of patients. NSABP B-51, omitting regional node irradiation after a nodal complete response after primary systemic therapy. Here, the question is, may I de-escalate radiation treatment in initially node positive patients who convert to node negative after primary systemic therapy? This is the design, patient receiving regional node irradiation or not receiving regional node irradiation with a primary endpoint of invasive breast cancer recurrence-free interval. More than 1,600 patients enrolled, a median follow-up of 60 months. The primary and secondary outcomes show no differences in terms of invasive breast cancer recurrence-free interval with an hazard ratio of 0.88. The event-free survival difference is basically the same, 92% as compared to 92% in non-irradiation, non-impacts in local relapse-free survival, distant metastasis-free interval, disease-free survival, and overall survival, not unexpected adverse events. So basically, the interpretation of these results supports, again, de-escalation, so omission of regional node irradiation for selected patients achieving nodal pathological complete response. Of course, we need to evaluate, again, baseline burden, tumor biology, systemic therapy, and surgical details to consider these results really totally overall practice changing. But again, these results reinforce the multidisciplinary discussion and the alignment with the evolving guidelines around post-mastectomy radiotherapy and indication to regional node irradiation after primary systemic therapy. At the same time, high-risk patients in 2025 were presented data with the Danish breast cancer group internal mammary node 2 study So internally mammary node irradiation with modern systemic therapy and conformal radiotherapy is another important historical question on randomized trial that showed overall survival benefit from internal mammary node irradiation. So the question is whether this benefit persists with the newer systemic therapy and conformal radiation therapy. The design of the trial: prospective nationwide population-based cohort with prospective allocation based on laterality. Right side patient received the internal mammary node, left sided did not receive internal mammary nodes. Systemic therapy include modern radiotherapy, endocrine therapy, and biological treatment. Population total include patients, more than 4,000 patients. Primary endpoint, overall survival. At the median follow-up of 13 years for overall survival, the 15 years overall survival rates basically show a 65% of rate in patients receiving internal mammary node irradiation as compared to 60% if patient did not receiving irradiation with in favor of radiotherapy, both for breast cancer mortality and distant metastasis. No subgroup, so basically identified omission of internal mammary nodes treatment as safe. We did not observe cardiac mortality signal, so the 15 years cumulative incidence of death from ischemic of heart disease was below 1%. So basically, in these patients, internally mammary node irradiation was associated with improved long-term outcomes, even in the era of newer systemic therapy and conformal radiation therapy. So in high-risk patients where the regional node indication exists, basically there is no clear safe omission subgroup for internal mammary node that emerged. So this supports continuous consideration of internal mammary node irradiation in node positive disease, while of course continuing to optimize heart sparing techniques, individualizing competing risk. The EXTEND trial adding metastasis-directed radiotherapy to systemic therapy in oligometastatic breast cancer. Here, the clinical question is if does really adding definitive metastasis-directed therapy to all sites of metastasis improve progression-free survival as compared to systemic therapy alone in oligometastatic breast cancer. We know there are conflicting data and results currently presented. This is a multicenter randomized phase 2 basket trial, patient randomized 1-to-1 to receive MDT plus standard of care systemic therapy as compared to standard of care systemic therapy alone, stratification based on number of metastases and prior lines of systemic therapy and hormonal receptor status. The primary endpoint, progression-free survival, median progression-free survival at a median follow-up of 24 months, so very, very early. No differences between patients receiving MDT or not receiving MDT to all the metastatic sites. No improvement in overall survival concerning secondary exploratory endpoints at 24 months of median follow-up. So basically interpretation, this small heterogeneous phase 2 cohort study basically adding metastasis-directed therapy did not improve progression-free survival or other key outcomes. So in principle, this does not support on a routine-based MDT for systemic benefit in this unselected oligometastatic breast cancer, but the study reinforced the need for a better selection based on biology, disease kinetics, burden of disease, and the real definition of the oligometastatic state and adequately powered trial. So still might have a role MDT, but should be investigated in ongoing phase 3 trials like the Taormina trial, for example, that is currently ongoing, randomizing patients to receive MDT or not in breast cancer. Let's change the topic. Ablative preoperative single fraction partial breast dose escalation trial, phase 1 or randomized dose escalation trials in patients receiving 30 gray, 34 or 38 gray in single fraction with endocrine therapy. So we have hormone receptor positive and negative patients not requiring chemotherapy with a primary endpoint here of maximum tolerated dose 44 patients as a population, as stratified as you can see here from the slides in the three cohorts of those. MTD falls and reach up to 38 gray with no significant acute adverse events, a 35% toward 66% for patients receiving 38 gray in single fraction of pathological complete response. If we consider pathological complete response plus near pathological complete response, we obtain a 93% of rate in patients receiving 38 gray and a local control of 100%. Interpretation of results presented by Raimi and colleagues, feasible option up to 38 gray in single fraction, preoperative stereotactic partial breast irradiation with delayed surgery plus endocrine therapy with high rates of pathological or near pathological complete response. An important signal, the timing prolonging interval to surgery correlate more with strongly, but this is of course well known based on radiobiology and the effect of ionizing radiation in breast cancer is strongly related with a higher rate of pathological complete response. Concerning guidelines, 2025 offered the Astro, ESCO, and Surgical Society post-mastectomy radiotherapy guidelines concerning indication after upfront mastectomy, after neoadjuvant systemic therapy, and planning technique recommendation, including hypofractionation and breath hold by the American societies. Basically, these are the key recommendations concerning upfront mastectomy, post-mastectomy radiotherapy. It's indicated for most node positive patients and selected node negative patients. After primary systemic therapy, post-mastectomy radiotherapy is recommended for locally advanced presentation and, of course, for residual nodal disease at surgery, regardless the status of clinical assessment. There are some conditional post-mastectomy radiotherapy indication for CT1 to 3 and 1 or CT3 and 0 with nodal negative status after primary systemic therapy. Concerning fractionation, moderate hypofractionation should be the preferred option. So these are consolidated and pragmatic risk-adapted framework guidelines with strong technical message, use model planning, contouring guidelines, heart-lung sparing techniques with a preference for moderate hypofractionation for our patients. We published during 2025 a biomarker-directed breast radiotherapy narrative review on the JAMA Oncologist. A pleasure to work with Charlotte Coles, Interim, and the Assisi think tank meeting group. This narrative review published on JAMA Oncology summarized the evidence on prognostic as compared to predictive biomarkers for guiding breast radiation therapy decision. We discussed topics of genomic signatures and classifier, immunohistochemistry markers, and tumor immune microenvironment, the concept of GARD, ongoing trials in DCS and invasive disease. Key topics, clear distinction needed between prognostic as compared to predictive value of biomarkers when we talk about radiation therapy, and evidence-based remain heterogeneous. Robust validation and prospective trials are still required before a routine use of biomarker-based omission intensification. So if you look at the clinical utility data, basically none of the current genomic testing available demonstrated clinical utility yet. So the interpretation is that biomarker-directed is, of course, a potential pathway to personalized omission or intensification of treatment in the future, but still requires rigorous validation and clinically meaningful endpoints. So it's really important to have a shared decision-making that remains, of course, central for our patients. It should be a main topic in terms of research. And finally, the Astro perspectives were published on preoperative radiation therapy in breast cancer from the guideline group on breast cancer, published by Alice Zamagni and Philip Portmans as chair of the guidelines. The ESTO guidelines committee approved the expert panel. There were 4 working groups across key clinical settings on low risk, high risk disease, and mastectomy indication for reconstruction. These are the evidence-based summary. More than 25 studies consider, more than 2,000 patients included across settings, more than 300 patients in low-risk setting, 10 studies in the high-risk setting, and 7 studies considered in the mastectomy reconstruction setting. So there are still some limitations, but it's really appealing the preoperative radiotherapy option in breast cancer. These are the main position, not formal guidelines. It's more an expert perspectives currently to inform trial design and research priority given to insufficient practice-changing evidence, but future phase 3 randomized clinical control trial need to define the optimal dose fractionation, interval with surgery, combination, of course, with systemic therapy. But this paper really offer excellent structure map of where preoperative radiotherapy might stand in the future. So coming to conclusion of this exciting 20-25 years, at least 5 points. De-escalation after neoadjuvant therapy, data from the NSABP B-51 trial in patient nodal positive that convert in nodal negative after primary systemic therapy. There might be room for de-escalation of regional nodal irradiation in selected patients. This might have a direct impact on decision on a multidisciplinary setting. Import low partial breast irradiation delivered with IMRT, non-inferior to whole breast irradiation, long-term follow-up results. So partial breast is a mature standard option in low-risk patients as compared to whole breast irradiation. The SUPREMO trial supporting in selected patient de-escalation of post-mastectomy radiotherapy based on risk and patient factors, but reflect a current practice that's completely different than the patients that were enrolled in the trial. Internal mammary node irradiation still matters, especially in high-risk patients, improve overall survival, decrease breast cancer mortality and distant metastasis. There is no subgroup evidence for safe for omission, should be always considered standard in node-positive disease. The Interim of EUROPA trial in patient age more than 70 years old, luminal like after breast conservative surgery, open room for de-escalation, not only concerning de-escalation of endocrine therapy, but also radiation therapy as a potential single modalities, but these are preliminary results. So basically 2025 is not about doing more, it's about doing less, but when safe, still doing enough for our patients that really matters. So less nodal irradiation, in good response after primary systemic therapy. So the concept of integration with systemic therapy, less whole breast treatment in low-risk disease. We should favor partial breast irradiation in selected cases. But of course, we have to continue our attention to be very, very strong in high-risk patients, adding internal mammary nodes in the real high-risk patients. So thank you very much for your kind attention. We are waiting for an amazing, exciting year 2026. See you next year.